This is Dr. Joseph Walrath, oculoplastic surgeon, talking to you today about upper eyelid surgery in general. This is an overview talk. It goes with a couple of other talks which zero in on some of the specific types of eyelid surgeries that I do and the specific types of problems that I solve. I'm an eyelid surgeon. I don't do butt lifts. I don't do breast lifts. I don't do face lifts. I do eyelid surgery, and a lot of it, about 1,000 surgeries a year. The topic today about the basics of eyelid surgery are going to include the definition of droopy eyelids, what that means to patients and what that means to me, and how we can make sense of the specific nature of the problem we're trying to solve. We're going to talk about medical requirements and what makes a procedure medical and what makes it cosmetic. We're going to talk about what patients need to do to prepare for surgery, recover from surgery, and of course, what the risks of surgery are. So what's a droopy eyelid? Patient comes to me and they say, my eyelids are droopy, and I look at three things. I look at their eyebrows. Could they mean that their eyebrows are droopy? Or do they mean there's a lot of extra fatty tissue or skin between the eyelid and the eyebrow? And that's what they're talking about. Or do they truly have a drooping eyelid margin where the lashes come off? That's called ptosis. Pro tip, that's a silent P, pronounced ptosis of the eyelid. So, how do we fix the droop? We can do a brow lift, and I consider that raising the curtain rod. We could also do a blepharoplasty of the upper eyelids, and I think of that as trimming the curtains beneath the curtain rod. And finally, we could open the window by doing a ptosis repair. Now, we could also, in some patients, do a brow lift and ptosis repair. You can raise the curtain rod and open the window, or you can trim the curtains and open the window, or you can trim the curtains on both sides and open the window on one side to balance things out. This is an example of raising the curtain rod. This is a brow lift in the middle of surgery. Rather, it's half a brow lift. On the left side of the screen, you see this lady has had an incision right above her brow. That brow lift has been completed on that side. On the other side of the screen, the incision has been drawn, but the surgery has not yet been performed. You can see the incision is located at the top of the eyebrow, and you can see the difference in eyebrow between the lashes and the eyebrow significantly greater on the operated side, with the patient's other side not yet being complete. This is a similar kind of photo for trimming the curtains, where on the left side of the screen the surgery's been done, and on the right side of the screen it hasn't been done yet. On the left side of the screen you can see the incision is neatly placed in the lid crease. You never see that when the eyes are open. You really don't see it when the eyes are closed. It heals so nicely. And speaking of eyelid closure, you should have normal eyelid closure after a surgery like this. How do you ensure that? Well, take a measurement, then I draw it, then I measure it again. Measure twice, cut once, and patients have good outcomes. This is a patient with ptosis. This is not actually demonstrating the repair, but just demonstrating the finding of ptosis. On the right side of the screen, that lid where the lashes come off is down into the pupil. On the other side of the screen, it's a normal height. So that is ptosis, and there's no amount of skin that you remove that makes both sides look the same. You actually have to open the window by tightening some tendons internally. There's a separate video on the several different ways that I tighten that tendon and lift the window open. So, patients always want to know who's going to pay for this, or more precisely, when is the surgery medical and when is it cosmetic? So, medical problem is when you take something that's abnormal and you make it normal. A cosmetic problem is when you take something that's normal and you make it another version normal. Pragmatically speaking, cosmetic is when you pay for it, and medical is when somebody else pays for it. Medicare says that lid has to get down into the pupil, or the tissue has to get down into the pupil to have surgery covered. And most commercial insurances kind of follow that. Sometimes insurance will pay for a portion of the procedure. So for example, Medicare may say, well, we'll pay for the brow, but you're on your own for doing an upper blepharoplasty. Or we'll pay for the brow and ptosis on one side, but the other side does not meet the medical criteria, and therefore you're on your own for that. Or some people say, well, if I'm going to be there getting my upper lids done, I'll just pitch in and fix my lower lids to make them look more youthful at the same time. So in that case, insurance often would pay for upper lid, but you're on your own for the lower lids. So that's kind of how it works with insurance. My office is very skilled at dealing with that. How do you prepare for surgery? Well, pretty much if you could walk into my office, you can have eyelid surgery. And if you can walk into my office while swiping your credit card, you can have cosmetic eyelid surgery. Age is not a consideration. It doesn't matter if you're 90, it doesn't matter if you're 1 year old. A lot of my adult surgeries perform with patients awake and they have a good experience. From a medical standpoint, if you're on a blood thinner, your internist has to say it's okay to lay off of that. I never actually tell patients to stop anything that's a potential life-saving medication. In terms of levels of anesthesia, as I said, it could be done under general anesthesia, and some patients say, no way, doc, I cannot be awake for this. It freaks me out. Fine, have general anesthesia. That's pretty rare, though. Some patients say, doc, I don't want anything. I am concerned about anesthesia. Do not give me anything. Those patients I do in the office wide awake, and they also have a good experience. Now, your health can dictate where we do the surgery. If you're on home oxygen, we're not going to do that surgery in the office. And we're not going to do it in an ambulatory surgical center. It's going to be done in a hospital day surgery center. If you have a cardiac defibrillator that could potentially shock your heart back into rhythm, if you've had a history of heart attacks or arrhythmias, that's done in a hospital day surgery center. A full list of preoperative instructions can be downloaded from my website. As I said before, this surgery could be done wide awake, and this guy had such a good time he wanted a group photo. This was back before the time of social distancing, and we're all hanging out with masks down. Of course, that doesn't happen anymore. In terms of postoperative care, it's pretty easy. First 3 days, rest, ice, comfy chair. Tylenol and Motrin for pain, something like that if you can take it. I generally do not prescribe narcotics for these upper eyelid surgeries. For the first 2 weeks, stay in a clean environment, light normal activity. If you wear contact lenses, take a break for 2 weeks. If you're going to do yoga, Pilates, base jumping, powerlifting, give it 3 weeks before you do that stuff. In terms of follow-up visits, there's a post-operative visit at 1 to 2 weeks and another one down the line a couple of months. These can be in office, they could be virtual or telemedicine, as I typically use dissolvable sutures. In general, a full list of post-operative instructions can be downloaded from my website. This is a gentleman every day after upper eyelid surgery, so you can't expect to look good on day 2. Nobody does. But by day 8, day 7, not too bad. The other thing to notice, there's smiley faces every day. It's not a particularly painful course. This is the long-term incisional healing from upper blepharoplasty. The incisions in lid crease. I do this incision perhaps 1,000 times a year or so. I revise 1 or 2 of them because of the appearance of the incision. I inject a handful of them along the way to get the incisions to behave the way I want them to. It's pretty unusual. Your expectation should be that this scar is essentially invisible after it heals over a couple of months. While it is visible, it's still not a problem because it's in your eyelid crease, and when the eyes are open, you don't see it. What are the risks of upper eyelid surgery? Well, you could have excessive bleeding. That happens to me once or twice a year. In general, that's not consequential. It just delays the healing, which is annoying, but doesn't affect your outcome. You can have reoperation. Now, most of the time what this means is, hey doc, there's a little extra skin in this spot. Can you remove it? No problem. We do in the office. Not a big deal. There's a specific reoperation risk for ptosis repair, which I'll talk about in an accompanying video. Infection is essentially unheard of in upper blepharoplasty because the eyelid has such a good blood supply to fight infection. In ptosis repair, there is a risk of infection. I'll talk about that in a separate video. Worsening dry eye, you should not expect that from upper blepharoplasty. You could have that in ptosis repair, and again, that's another discussion in another video. Once again, this has been Dr. Joseph Walrath, and this is my team. I hope this presentation has been enjoyable and has explained a bit about oculoplastic surgery. Whether your problem is medical or cosmetic, I'll certainly do my best to help you reach your goals, and I look forward to meeting you.